carried a compound heterogeneous mutation of HBE and beta thalassemia. So since that event, this child required a 4 to 6 weekly blood transfusion. So only then that the couple realized that they are actually carried a thalassemia mutation. The mother carried HBE trait while the father carried a beta thalassemia carrier. So in 2019, for the second pregnancy, they conceived spontaneously, and at that time, amniocentesis at 20 weeks confirmed that the fetus was a beta thalassemia carrier, and also at that time she was delivered at 39 weeks by emergency cesarean section for fetal distress, and a baby girl was delivered with birth weight of 3.0 kilogram and confirmed a beta thalassemia carrier. So actually HLA typing was performed for the second child as a potential donor sibling. Unfortunately, she was not HLA matched with her affected brother. So she could not serve as a stem cell donor. So after a multidisciplinary counseling, the couple decided to proceed with another IVF cycle with PGTM and also HLA testing. So to search for HLA matched donor sibling. Actually, this procedure was performed at Sanford Hospital, and at that time, able to obtain 5 embryos. So for the third pregnancy, the embryo that was selected is a HLA match with the elder brother. So in 2022, frozen embryo transfer was performed, and the HLA match, however, thalassemia carrier embryo was selected. And the pregnancy progressed well. She delivered at 37 weeks by elective cesarean section for 2 previous scar, and cord blood was collected during the C-section. So 2 years after that, the cord blood hematopoietic stem cell transplantation was successfully performed for the elder brother with the HPE beta thalassemia. So since the procedure, the brother has remained transfusion independent. So to complete the family for the 4th child, last year another frozen embryo transfer was performed, and a normal embryo was selected, and also the pregnancy went well, but ended up with emergency cesarean section for 3 previous car in labor, and delivered a healthy baby boy. So this is a summary of the family pedigree of Mr. F and Madam N. So they actually got married without unaware that they are actually both thalassemia carrier, and the first son was actually affected by the thalassemia, needing a lifelong blood transfusion. However, with the advanced reproductive technology, with the presence of PGTM and HLA typing, we can select the HLA matched embryo, and having the third daughter for the sibling, sibling donor for the brother. So with that, I thank you.
So I will continue with AF's, the index case transplant journey. So AF was being prepared for transplant, in which he was being regularly transfused 4 weekly with the aim to ensure there is no extramedullary hemopoiesis and there is optimal growth. At that point of time, AF has no organomegaly, no thalassemia skeletal changes, and he is thriving, growing along 25th to 50th centile. He also received chelation with the aim to keep the ferritin below 1,000. His viral screening, hepatitis B, C, and HIV were all non-reactive, but he was seropositive for CMV and EBV. So his donor, who is the newborn sister MA, was being well prepared for transplant as well. She's a thriving child growing along 50th centile. So her FBC at 5 months old actually shows hypochromic microcytic anemia, but the beta genotype was reported to be normal. However, take note that this is a limited panel in which the father's genotype was not actually included in this testing panel. Given her pre-implantation diagnosis, her genotype is likely codon 35 mutation inherited from the father. So a confirmatory HLA typing was done at the age of 8 months, which confirms that she is fully matched with AF. Her viral screening Hep B, C, and HIV were also non-reactive, and she was also seropositive for CMV and EBV. So we proceeded with hematopoietic stem cell transplant when the donor is 1 year, 3 months old with the weight of 10 kilo. 1 month prior to transplant, AF was admitted to our transplant ward and given intensive chelation and also to suppress the erythropoiesis with weekly transfusion with the aim to keep HB above 12. Subsequently, he received myeloablative conditioning, and also he was given graft versus host disease prophylaxis with IV methotrexate and also cyclosporine. And eventually, bone marrow harvest was being done on the 30th of May 2024 under general anesthesia, and a total marrow volume of 215 mils was harvested, which is around 20 mils per kilo of donor weight. And this was CD34, 2.77 million cell dose per kilo of recipient body weight. So AF received fresh marrow infusion immediately after the harvest in the morning, followed by cord blood thawing and infusion in the evening. So she has no major complications post-transplant, and ANC engraftment with a platelet engraftment were able to be achieved on day 16 and 20 post-transplant respectively. And he was discharged well on day 34 post-transplant. So currently AF is around 1 year, 7 months post-transplant. Donor chimerism at day 30, 90, 180, and 360 post-transplant were all 100%. His HB now still having mild hypochromic microcytic anemia, as he's now a beta thalassemia trait, given that his donor is a beta thalassemia trait as well. He remains transfusion-free since then, and he has no chronic graft versus host disease. Post-transplant vaccination is still ongoing, and he already back to school as usual. Thank you.
So I hope you guys understand the situation. Now, I would like to proceed with what we have in Malaysia currently and what we can offer for the patient. As you know that they are married, the love is beyond the thalassemia trait, right? Because they didn't screen for the thalassemia trait before they holding the hands. So this is one of the lesson for medical student, screen before you hold hand. So basically, this is autosomal recessive hemoglobin disorder, which is high prevalent in Southeast Asia. The severe form required lifeline transfusion, like our index case, and curative option is only hematopoietic stem cell transplantation, and we have the option of PGTM HLA matching. So first and foremost, I want to introduce you what is PGTM. PGTM is pre-implantation genetic testing for monogenic disorder, and it performed via IVF treatment, and we can detect the monogenic diseases, such as in this case thalassemia, and we can prevent this for transmission in the next generation in life. So we have PGTA, which is the aneuploidy, to detect any Down syndrome, Edward or Patau, or any other X-linked chromosome syndrome, especially in elderly couple. And we have PGT-SR, which is structural arrangement that is more on chromosome translocation, which is not really popular in Malaysia. It's more in overseas setting. So we have two that be implemented in Malaysia widely, which is PGTA and also PGTM. Before we go for PGTM, we need a detailed genetic counseling to be offered for the couple, and we need to do an HLA matching workup for the recipient first before we want to know what is the HLA type that we want to harvest. So as usual, IVF will be done in usual manner with ICSI procedure, and the biopsy will done once the embryo reach blastocyst stage. So we do PGTM to identify unaffected embryos, and we do HLA matching to identify possible unaffected HLA matching embryo, and we also need to couple PGTM with PGTA because we don't want to have a normal thalassemia trait but Down syndrome. So we want to have a normal chromosome with unaffected disease, and we will transfer this unaffected HLA matching embryo, and when this birth of this baby arrive, we need to test back whether the HLA matching that we harvest during the blastocyst stage is correlate or correspond or not after the age of 6 months old, because already optimum the erythropoiesis in the body. So in our case, the confirmation test was done in 8 months old and is consistent with our HLA matching during the blastocyst stage. So this is what I mentioned before, that we need to do a tropoectoderm biopsy, and we do a PGTM test, and they will come back as normal, carrier affected, or inconclusive result if the cell is not adequate for PCR and also gene analysis. So for the HLA matching sibling donor program, we need to escalate this HLA matching from the paternal and maternal side itself, as well as to correlate with the pattern inherited by the patient. So it's very specific that we need to have HLA matching, because as what Jun said, we need to prevent the graft versus host disease that will occur if you do any transplantation. So prior to the PGTM, what we should do as a prerequisite, we need to screen both couple and understand their genetic mutation analysis. As been mentioned before, wife with the mother is codon deletion at 26 mutation, and the husband is CD35 mutation. So as I just want to go through what is this codon all about, because this is the two type of genetic mutation that commonly occur in beta globin gene and seen in thalassemia patient in Southeast Asia. And you can see that the CD26 is mild as compared to CD35. However, if this combination of 35 and 26, it become the most severe case that represent in our index case, which is thalassemia major. So this is the comparison of CD26 and CD35 mutation. You can see that both are beta thalassemia. One is mild, one is severe, and the mechanism due to the amino acid substitution and also frame shift leading to the stop the codon and impact in the beta genes. So this is PGTM. When we talk about PGTM, you need to know that the patient need to understand that the embryo lifespan need to go beyond day 3, because day 3 embryo is cleavage stage and day 5 embryo is blastocyst state, whereby day 3 you cannot do a biopsy. Why? Because the optimization of the gene is not yet there. That's why you need to push to blastocyst state. Some caught by surprise where they have very bad sperm and very bad oocyte, whereby when we do the fertilization, the embryo arrested or die at day 4. So they need to repeatedly do the IVF in order to get the blastocyst. All right, then when you got the blastocyst, you need to do PGTA first. I have a couple who is married to the first cousin, and the blastocyst PGTA always come back as abnormal baby. All right, that's why they cannot proceed to PGTM, because all the baby is abnormal in the first hand when we screen with PGTA. So that is the hurdle. Don't think that we have PGTM. You can hold hand with carrier and carrier. So looking back into this case, this is the real result that we get from this case when I'm part of the team of managing this case. So this is the codon that we know that we have 4 blastocysts. 4 blastocysts that arrive from the IVF. We have 4BA, 4BB, 3AP, and 3CC, which is the classification of grading of day 3 embryo. And you can see that, fortunately, we have one which is unaffected, which is the embryo number 2, euploid XY, which is baby boy. However, this is good for us because he have 4 good euploid embryo, which is normal baby, and only 1 monosomy 19 XY that we need to discard. So based on this, we further mapping the HLA matching. You can see that embryo number 1 carrier is not HLA not fully matched, Embryo number 2 that we hope that is normal and matching is not ever HLA match. And embryo number 3, which also a carrier from the paternal side, is HLA fully matched. And embryo number 4 is not fully matched. What if all the embryo is not fully matched? So you don't have an option for HLA. You need to repeat back your PGTA and PGTM. And it's not cheap. It's 50,000 ringgit. 50,000, 50,000, betul. Okay? Because all the workup and things like that is very expensive. So based on this, as mentioned by Jun, we're able to get the HLA matching and we're able to transplant the embryo, and fortunately the embryo survived and delivered healthily, and we're able to do a blood receiving donor Saviour. So based on this, my team and my geneticists published this pre-implantation genetic testing and LH matching with healthy donor in Malaysian journal. So if you able to have to go across this publication, you can go across of this case today. So why we bring the CPC today? Because I'm a part of the management of thalassemia second edition that we launched this year, January, by Ministry of Health. We already put on the PGTM testing as a recommendation for the couple who screen that they are thalassemia carrier before they start the reproductive life to prevent the transmission of beta thalassemia gene to the offspring. Malaysia are very ambitious. They said that we want to have zero thalassemia by 2030. But when the stockholder come, we offer them to give us subsidized for PGTM. They said there's no money, of course lah. Then that's why we offer this PGTM in Malaysia, because we have that. And the second that we recommend in our PGT is once you have a affected baby, like what is our index case, then we need to search for HLA matching from the sibling itself, because you know that 25% is normal, 50% is carrier, and 25% is affected based on the pedigree of autosomal recessive. So you can screen first of the sibling, then we can go for HLA matching. But I just want to highlight when Jun said that the index case received cyclophosphamide and all this cofalosporin, the reproductive carrier of the boy is gone because they have a very genotoxic chemo prior to transplant. Unfortunately, at this age, we cannot salvage the sperm for freezing. So for fertility preservation, I hope this year in Malaysia, we can start prepubertal testicular tissue cryopreservation for this kind of cases. So we will try to get the stockholder come in for us to do a testicular tissue freezing for prepubertal. So hopefully, on top of they are healthy, they can become transporter dependent, they can also become a parent in future. With that, thank you very much.
Assalamualaikum and good morning. So we'll look into the management of pregnancy in couple with beta thalassemia. So I'm not going to go into detail about this inheritance of thalassemia. I think it has been described in detail just now. So if you have a couple with thalassemia trait, we're talking about beta. Beta thalassemia for both husband and wife. If they choose to do a prenatal diagnosis of their offspring, right? So you can offer them either the earliest is CVS, but we don't have it here in our center. The timing to do it is around 11 to 15 weeks, and the risk of miscarriage is less than 0.5%. So you can either approach a CVS transabdominally or transvaginally, depending on the where the placenta site is. So what we have in our center is amniocentesis. So we can do this more than 15 weeks of gestation. So you can offer the patient, if you want a prenatal diagnosis of your offspring, so you can go through amniocentesis, the earliest around 16 weeks, right? And the risk of miscarriage is quite low, less than 0.5%. So it is quite a safe procedure and can be done as early as 16 weeks in our center. So in regards to antenatal issues, there's really nothing much extra or special regarding the management of couple with beta thalassemia trait. So what you want to look out for is, of course, anemia, and also you want to make sure she doesn't have a concurrent iron deficiency, which can aggravate the anemia. So your supplement standard will be obimin if she is not having iron deficiency. But once you diagnose her to have iron deficiency, then you can change the oral prep from obimin, which is low in iron content, to a higher one, either is iburet, maltopher, or zincofer. Right. So in regards to the fetus, please look out for small for gestational age or fetal growth restriction. So you need to monitor the fetal growth. Time of delivery as per normal, meaning that if they have no other complications such as diabetes, hypertension, so you can allow the pregnancy to progress on its own and they can come in spontaneous labor. If not, they can be delivered at post-date 7 days. Mode of delivery based on obstetric indications. So if there's no problem, you can go for vaginal delivery. If there is PVR major, you can go for cesarean section. Intrapartum, as for any other patients with anemia, make sure she gets she has a full blood count and GSH intrapartum, and active third stage management, whereby you want to make sure that she doesn't go into postpartum hemorrhage. And of course, we know that patients who are anemic are a high risk for postpartum hemorrhage. So after postpartum, during the postpartum period, make sure you repeat the hemoglobin before you discharge the patient. And based on the level of hemoglobin, you would want to consider either blood transfusion, and iron therapy is only reserved if you have iron deficiency on board. And this iron therapy can also be done antenatally if she has iron deficiency, but we try to avoid iron therapy in thalassemia patients. Contraception, we try to choose methods that do not cause heavy menstrual bleed. So you can go through all these lists: condom, COCP, POP, implanon, Mirena, coitus interruptus, and rhythm method. So all this is acceptable for thalassemic patients. The one that we try to avoid is always the copper IUCD because it is associated with heavier menstrual bleed. Thank you.
Morning, everybody. So I'll be talking about the transplant in thalassemia. So as mentioned earlier, you know that transplant is curative option for thalassemia patients. So we have come a long way since the transplant was first successful in 1981. In Malaysia, the first successful bone marrow transplant was performed in Institute Pediatrik Hospital Kuala Lumpur more than 2 decades ago. 2 years later, we have the first successful sibling cord blood transplant in 1999 done in UMMC. Now, who should go for the transplant and when it should be done? So of course, transfusion-dependent thalassemia, because of the long-term complications from the iron overload, we will screen them for possible donors. If it is available, we will advise them for transplant. It should be done as early as possible because it will have a lower mortality if you've done it earlier, and there will be less organ damage from the iron overload. So pre-transplant, we will actually re-stratify the patient based on the Pesaro risk classification, looking at the compliance to the chelation, presence of hepatomegaly, and also whether there's any liver fibrosis. They will be divided into 3 classes, where class 1, they will have a good compliance to the chelation. There are no hepatomegaly or liver fibrosis. And class 3 are poor compliance and presence of hepatomegaly and also liver fibrosis. Patients with class 1 and class 2 have a better survival outcome, more than 90%, whereas patients with class 3 has a poorer outcome of probably 70 to 80%. Now, looking for the donors, of course, you will need a matched sibling donor who are disease-free. This is because if you have a matched sibling donor, there will be less risk of graft failure and less risk of graft versus host disease. However, it is not easy to find a matched sibling donor where you only get a 30% chance of finding them. Now, if the donor is a thalassemia trait, we can still use them as a potential donor. Then the patient will become a thalassemia trait post-transplant. But that's okay, because your aim is to make the patient transfusion-free with good quality of life. Now, in this case, you will wonder why we wait for 1 year for the donor to be big before you proceed with the transplant. Why not do it immediately after the donor is delivered and you have the cord blood available? Okay, so now if you do the transplant with just the cord blood alone, okay, the cord blood, the amount is very little, so you will have a very small cell dose, which is inadequate. So the patient will take longer to engraft, and with the longer duration of wait, the patient has increased risk of getting an infection. And in the event that the transplant fails, okay, you don't have a backup. So you have to wait until the donor is a bit bigger, okay? So you have a backup in case the transplant fails. You can reharvest again the second time from the donor and do a second transplant. And of course, if the patient is bigger, the donor is bigger, okay, it's easier for the clinician to do the bone marrow harvest. Okay, for us to do a bone marrow harvest, we need to do more than 20 punches at each PSIS. And that is really, really painful if the patient is very, very small, okay, the area is very limited. So let's say if you don't have a donor who is a matched sibling, now we have other options available where people have done the transplant using a matched unrelated donor, means it's people from the public, but just so happens that they are HLM matched with you, okay? Or they can use an unrelated cord blood. And now people are even doing a haplo transplant using parents or unmatched sibling as a potential donor. So in Malaysia, the only center that is doing a haplo transplant for thalassemia at the moment is UMMC, but the outcome is probably only 50% to 60%. So we will ask whether the parents will always ask, after the transplant, can you guarantee that my child is going to be okay? So there's no guarantee in life, okay? So when we do the transplant, okay, the outcome will be depending on several factors. So I've mentioned earlier, based on the Pesaro classification, of course, class 1 will have a better outcome. If you have a matched sibling donor, of course, your outcome is also going to be better. You probably have a 90% thalassemia-free survival compared to if you are doing a haplo transplant of a 50%. If you refer the patient early for transplant, age less than 6, the outcome is about 90%, but if the patient is older, the survival is going to be lower. So complications during the transplant, there are a lot, okay, but the main cause of mortality usually is related to infection during the neutropenia phase. They will also have risk of organ injury because they have iron overload, so they are higher risk after the conditioning to get organ damage, and also from the graft versus host disease. And even if they survive the transplant, they will have long-term complications, for example, endocrine, cardiac, gonadal failure, secondary malignancy, and some of them may even have psychological issues. So interesting is we have now gene therapy, which is being used as an alternative to transplant, and this is now being done in developed countries such as US and UK. We hope that we can have this also in the future in Malaysia. So in conclusion, transplant is curative, but we need to make sure that we select the proper donor, make sure that the patient's pre-morbid status is optimized before the transplant to have a better outcome. And this patient will need a long-term follow-up for the complications. Thank you.
Okay, thank you very much to all our speakers. It's a very, very interesting case. So now we have Kahoot. So on the Kahoot, please.